All right, welcome back for our last lecture of chapter 14 and for the class altogether. So good job, we made it close to the end here. So in the notes, there's a section called classification of infectious diseases. I don't have any pictures to go along with that. I just have it here in my notes. So I just wanted to mention, make sure you look up the differences between acute, chronic, subacute, latent, communicable, and non-communicable. So just some definitions of those. So acute is a disease that develops rapidly, but usually goes away relatively quickly. Chronic is a slower development and a longer lasting condition. And then subacute is kind of in between acute and chronic. Latent disease usually lays dormant and unsymptomatic or asymptomatic for long periods of time before it starts showing signs and symptoms. Communicable is an infectious disease that can be transmitted from one infected host to the other, and a non-communicable disease is not spread from one host to another. It can be an infectious disease, but it might arise from your normal microbiota, like a yeast infection or something from a woman using antibiotics. It's not like the yeast infection was transmitted to her from somebody else. So those are just some definitions you can take a look at. So now we're going to get into kind of the bulk of the rest of this video is epidemiology, which is a study of the transmission of disease, how disease spreads in the communities, and what can be done to try to slow that spread. That was a whole thing of John Snow way back with cholera. We'll take another look at that here in this section of the video. First, just a couple terms. There's some new vocabulary that we have to kind of define and take a look at. So we have the terms incidence and prevalence. Now, before we dive down too much of this epidemiology stuff, and I know during this whole COVID thing, I logged in or I signed up for the Oregon Health Authority's daily text messages to tell me kind of the status of what's going on. So that's like real-time epidemiology, which is kind of cool because I always liked it to begin with. But when we talk about epidemiology, you have to focus on a particular period of time and a particular geographical location. So for example, I'm getting data from all of Oregon for that particular day. So my set time is that day, and then my set geographical location is Oregon. But then I also bring up Jackson County's information that's specific to just Jackson County, because that's more interesting to me, because what's happening up in Portland doesn't necessarily reflect what's happening down here in Southern Oregon. So I would like to get both bits of information. And they're going to be different because when you're talking about Oregon, you're talking about millions of people. When you're talking about Jackson County, you're talking about thousands of people as far as populations go. So when we talk about these numbers, incidence and prevalence and epidemics and pandemics and things, we are focusing on a particular geographical location at a particular period of time. So that's kind of the parameters of which these terms kind of play out. So when we take a look at incidence, it's the number of new cases in a given area in a population over a given time. So incidents are new cases. So that's kind of what we get every day. So if you subscribe to those text messages, it's been really depressing lately, kind of mid-July, is the numbers keep going up and up and up and up. So we had in Oregon, we were doing really good for a while, and then we got 200 something cases a day, 300 something cases a day, 400 something cases a day. So that is your incidence, new cases per day. So like in Jackson County, we were at like 2 and then 5, and then I think we went to 15 and then 9 and then 5. So those are incidents. When we take a look at prevalence, prevalence is the total number of cases in a particular time frame in a geographical region. So again, if we're going to say our time frame is from the very beginning, mid-March to now, which is kind of mid-July, it would be the total number of cases. I think Oregon's up to like 10,000 or 11,000. That would be the prevalence, with the incidence being 400 new cases today. In Jackson County today, we're at like 175, but there's only 5 new cases. So 5 cases would be the incidence, 175 would be the prevalence. So that's the difference between those two. So here's just a couple different graphs showing kind of the representation, some graphical representations of incidence and prevalence just in general, and then a particular example, I think that's of HIV from the mid-80s up to kind of the mid-2000s. Okay. Then if we're going to define some of these other terms, endemic, sporadic, epidemic, and pandemic, So endemic is just looking at disease that normally occurs with relative frequency. It's kind of what's normally there. So here in the United States could be our geographical region, Oregon could be our geographical region, Medford could be our geographical region. Whatever you're focused on, that's your parameter, we would have endemic diseases. So if you work in the county health department, you're used to seeing these diseases come through. So like rhinovirus and influenza and some of the childhood diseases that come through, chickenpox, those types of things. They're endemic. It's not going to be a big surprise that there's going to show up at these expected intervals because people have kept records and there's historical data to support that these diseases are typically found in that particular geographical region. Now, a sporadic disease, let's see, what does it say? Only a few scattered cases occur within an area or a population. So there might be an outbreak or a little sporadic outcropping of Campylobacter or listeriosis or E. coli infection, kind of those food-related ones might be considered a sporadic frequency of disease. Then we get epidemic, where you have a higher than normal number of that particular disease. And it could be out of the normal one, or it could be a normal one. So you could have an epidemic of influenza. We had the H1N1 swine flu back in 2009. It did turn into a pandemic, but it started out as an epidemic in certain parts of the world. When we get to the definition of a pandemic, it's multiple epidemics happening on 2 or more continents at one particular time frame. Now, when I was teaching this class winter term of 2020, when the whole COVID thing was developing, it was a very interesting time to be lecturing on this in March because my lecture was on a Thursday, and the prior Wednesday, the World Health Organization, had just announced COVID-19 as being a global pandemic, when before it was just an urgent health concern or whatever it was before the pandemic, even though it was clearly had become pandemic quite a ways before that announcement, kind of mid-March, because we had seen it in China, we had seen it in Europe, and we had started to see some cases in the United States. So that's clearly 3 continents. So they were just kind of, in my opinion, dragging their feet a little bit on making that announcement, but it is what it is. So a pandemic is when you have multiple epidemics in 2 or more continents around the country, around the world, in the same time frame. So that's what we're dealing with right now, is this global pandemic. It's just spreading, and it's a new disease. Coronavirus was not known to humans before November of 2019. Okay, so those are our definitions of endemic, sporadic, epidemic, and pandemic. So then we have another graphical representation to kind of maybe help illustrate the difference between endemic and an epidemic disease. So let's say we have a couple diseases labeled A and B. So A is the purple and B is the red, kind of zigzaggy lines. The blue lines would be our expected cases. So this is based on historical data. We have this curve, so the blue disease is more prevalent. There's a lot more of those that we can see in this particular location at this particular, looks like over 2 years of time. So in the purple, so this guy here, it's kind of pretty much tracking the expected outcome. So that's just regular endemic disease. For the red disease, disease B here, it starts to, and it kind of follows it for most of these cycles, but here, kind of in, looks like early 1999 and looks like early 2001, we had some higher than normal expected rates of this particular disease. This is what we would call an epidemic, so higher than normal, higher than expected rates. So that's one of the reasons why we have epidemiologists and health departments and health authorities for local, regional, state, and national, right? The CDC is a national disease center. So they can compile all this information to keep track of it to make sure if there is something that's out of the ordinary that can be addressed. Okay. So then when we take a look at epidemiology itself, here again is that map that John Snow made, and the water pump there is left behind to kind of in honor of his discovery of this tracking cholera and making the connection to contaminated water and a disease. There's different types of epidemiology. So this is just coming from the notes. We have descriptive epidemiology, analytical epidemiology, and experimental epidemiology. All of these different categories of this discipline work to try to find the cause of the disease. An index case is the first person to have that case, to have that disease. And if you can track down that index case, then that tells you a lot about maybe where that infection came from. So here's that pump at Broad and Cambridge Streets, and we can see these huge numbers of cases that are local to that particular pump. And when they took the handle off of that pump, the cases went down. So that is our epidemiology. This little picture here, I just kind of plopped that in because as I was doing some research on cholera and looking at its pathogenicity and its virulence factors, I found a cool little study where they were using quorum sensing chemicals to block the pathogenicity or the virulence of the cholera bacteria, which was kind of cool. So here is the normal, infections, the little orange guys. If they put in these genetically engineered bacteria to release these anti-quorum sensing molecules, it prevents the cholera from releasing its toxin and does not cause infection, which I thought was pretty cool. So there's a little extra quorum sensing, anti-quorum sensing antibiotics research for you. It's kind of cool. All right, so then we're going to take a look at hospital epidemiology. So this is what we call healthcare associated infections. Now I know a lot of students out there who are taking this class work in the healthcare field, and so you may be aware of some of these statistics already. It's not a pretty picture. There's actually quite a bit of infections that people get just from going to the hospital. Not that they were in there for that particular reason. Maybe they were in there for a knee surgery or some other reason. And then while they were in the hospital, they acquired this secondary infection. So this is an infographic that I found that kind of shows some of the statistics of these healthcare acquired infections. They used to be called nosocomial. That's the kind of term that's in my brain. So it's hard for me to remember to do the healthcare associated infections. It's a little bit harder to say. I like nosocomial, but it's kind of out of style. So if you are admitted to the hospital, you have a 5% chance of contracting a healthcare associated infection. That means out of 20 people, one person would get, out of 20 people admitted, one person would get a healthcare acquired infection. If you do get one, if your normal length of stay is 5 days, it increases your length of stay in the hospital by almost 20 days. So it's about 18 days longer you'd have to stay in the hospital over your original expected length of time you'd have to stay in the hospital. Almost 2 million people per year get a nosocomial infection. It costs the system about $35 billion, which is an extra $1,100 per person, which is about 9.4% of total costs of healthcare costs are due to healthcare acquired associations. Here comes the kitty. And then also, this is a huge statistic, about 70%, about 2/3 of people are people in Medicare and Medicaid, which means it's the government assisted health insurance, which typically means lower income and elderly people are the ones that are going to be seeing a majority of these healthcare acquired infections, which are the people who are least ready to handle higher costs and extended stays in hospital. Almost 100,000 people die in the US, just in the United States, from healthcare acquired infections. And it kills more people than breast cancer, prostate cancer combined. Right? So there's that almost 100,000. Breast cancer and prostate cancer looks like they count for maybe about 60,000 deaths. It's pretty sad. And here's the kicker. Most nosocomial infections, healthcare associated infections, are preventable, which is the sad kind of part to all those statistics we just talked about. So 80% of infections are spread by unwashed hands. Hand washing compliance rates in hospitals are averaging only about 40%. So you remember Semmelweis and his huge breakthrough with preventing deaths in those obstetrics wards. So even a couple hundreds years after his discovery, his observation, we still have a hard time washing our hands. And we are in the middle of a pandemic that people still struggle washing their hands. So it's such an easy practice, but it's easily overlooked as well. So this has some of the same statistics we had. Almost 100,000 people die, 1.7 million infections per year, and 1 out of 20 people are admitted are going to acquire a healthcare associated infection. So these are the two things that are kind of new in this particular infographic, that 80% of them are spread by dirty hands, and that only 40% of people in healthcare situations don't wash their hands properly. So if you are in that environment, a lot of you are going off into that field, whether you're nursing, respiratory therapy, paramedic, emergency medicine, whatever you're going into, please make sure you're following proper hand washing techniques. And if you see people not following it, speak up if you can. If you're that kind of person, gently and kindly just remind people that this is a serious condition. And then we have a perfect storm here of people in the hospital are immunocompromised. There are microbes in the hospital environment, and there's a lot of interaction between patients, between healthcare providers and their patients, and between visitors and patients. So all three of those together increase the chances that somebody is going to get a healthcare acquired infection. All right, so it's really important to kind of follow the guidelines and the procedures for minimizing the risk of healthcare associated infections. So washing your hands, make sure you're following your sharps procedures. So you put the sharps in the sharp container, you don't resheath them, protective barriers, and wash hands before and after coming into contact with anything that might be infectious. All right, so I think that wraps up. Yay, we're done. Good job, everybody. So that's the end of our chapter 14 material and the end of all of our microbiology material. So I hope you had a good term, and I won't see you next time. This is our last one. So thanks so much for a great term, and hopefully I will see you around whenever things hopefully get back to normal soon. All right, stay safe. I will see you next time, or not. Okay, bye.